University of South Carolina, and then went on to do her postdoc at the Fred Hutch Cancer Center. Dr. Irwin has funding from everybody, so she's been funded from the American Cancer Society, American Institute of Cancer Research, Komen, and of course the NIH. So I think most of you saw her CV, pages and pages of grants. But I will say I'm biased that my favorite one is her TREC, so Transdisciplinary Research in Energetics and Cancer Training Workshop Grant, mostly because it directly benefited me. In many ways, it was a really fantastic learning experience. I got to interact with Dr. Thompson, who was here, and I barely met, so we had to go all the way to Connecticut to meet. So that is probably my favorite grant, so I'd like to
it's my favorite too.
Thank you for that. And also, I was formally paired with Melinda as a mentor, so she had no choice but to come here. So anyways, please welcome Dr. Irwin, and we're really excited to have you.
It's been such a great visit, so thank you, Heather, for inviting me. And it's really nice for me to get perspective and see how this department works in comparison to my department or my school, and just really from the student perspective, and how it's all a little bit different, how I can go back home and make it maybe even a better environment for our students from what I've learned here, because you do have a really good setup, guys. So enjoy it. Yeah. So I'm going to talk about the impact of exercise and weight management interventions in cancer survivors, mostly focused on breast cancer, but I think you can think about how it could extend to other obesity-related cancers as well. And really where I am now in my career is thinking about how we can, the future research direction to inform implementation of all the efficacy trials that we're doing to be implemented in the clinic as a part of standard of care. So I'll kind of take you along some of the research I've done and where I want to go and where I think the field is going as well. Okay, so as many of you might know, about 1.7 million new diagnoses of cancer every year. Half of them in men, half in women. This is just in the United States. And this has increased. The incidence of cancer is increasing every year, partly due to earlier detection and better screening. The good news is our mortality rate has declined by about 25% since its peak in the 1990s. So this 25% decline in cancer mortality rates is primarily due to the primary factor. Does anyone know what the main driver of this decline in cancer mortality rates is? Take a guess. Smoking cessation. So exactly. So a majority of that reduction in cancer mortality rates is because the improvements in tobacco control or cessation over the years, and that's a modifiable lifestyle behavior. So there's a lot that we can learn from that behavior and apply it to sort of energy balance, exercise, nutrition, and weight management. But yes, also some of it due to the improvements in adjuvant treatments, earlier detection. So together, an increased incidence and a decrease in mortality rates or a longer survival rate has led to an increase in the survivors across the United States and globally. So right now, at about 2020, we're about 15 million cancer survivors in the United States. But as you can see, this is going to increase over the next decade or two or so decades to about more than 25 million. And the majority of these will be older adults, so over the age of 65, 73%. So right there is a research question. Studying the impact of these interventions, exercise or whatnot, in an aging population. And all these, so if you take a cancer population, what are the other comorbidities that go along with aging and side effects and whatnot, and really thinking about that from the perspective of aging. And there's NIA right now, so the NCI I think has a pay line of about 8%, but NIA has a pay line of funding that's well over 20% right now, the 20th percentile. So thinking about that. Okay, so what's the rationale of studying lifestyle behaviors and cancer outcomes? To me, it's quite easy, and hopefully to many of you, that we know that its surgery and treatment are associated with several long-term side effects. Weight gain, so many people think people lose weight with a cancer diagnosis and its treatments. That may have been many years ago, but now because of the anti-nausea medications and other treatments. There's actually not so much weight loss, but weight gain. Cardiovascular disease, so women with breast cancer, their primary cause of death is cardiovascular disease, not actually breast cancer. Diabetes, osteoporosis, quality of life, and then of course recurrence and new cancer diagnoses. So preventing weight gain, promoting weight loss, physical activity, and healthy eating may prevent and control some of these side effects, as well as be independently associated with recurrence and mortality endpoints. So there's so many different pathways where exercise or nutrition or weight management or energy balance can directly impact and indirectly impact cancer outcomes. So we talked briefly about tobacco. So tobacco and energy balance together are the two primary preventable causes of cancer mortality. And in fact, obesity and sedentary lifestyle together explain more of this than tobacco control. So when you hear kind of lay conversations or topics on this, like what is the primary factor, it's really the energy balance factors. So many don't realize that there are 14 different cancers that are associated with obesity, and therefore probably physical inactivity and diet. Many think it might just be breast or colorectal, but there's 14 different cancers that are associated with energy balance. And some of these are very understudied. So multiple myeloma, esophageal cancer, liver cancer. Liver cancer is growing in incidence. Is that because the prevalence of obesity is increasing across the country and globally? And is that explaining the increased incidence of liver cancer? So these are understudied areas that you want to think about. What if we apply maybe a breast cancer, and is that relevant to that other cancer, or are there different mechanisms? And so, these obesity-associated cancers, the concern is if there's 14 different cancers and we're still seeing an increase in incidence and prevalence of BMI. As you may have seen these maps hundreds of times before, in the 1990s, less than 15% had a BMI of 30 or greater. In 2010, 10 years later, if you look down at the dark blue, about 20 to 25% had a BMI of greater than 30, and then 2010, 1 in 3 had a BMI of 30 or greater. And it's projected, well, right now, it's at about 40% have a BMI of 30 or greater. So when you see these large increases in BMI over time, it's probably not due to something genetic going on, but changes in our built environment, right? And so when you think about physical activity, what's been the biggest change over the past 30 years? Is it our moderate and vigorous intensity physical activity, or is it our light intensity or our sedentary behaviors? What's changed the most? Yeah, and it's simply because of the technological advances, right? And there's an analysis that, what's his name? He's at Colorado, did, and I will get to his name, but he found that it's a 200 calorie deficit per day that's really explaining this large, on a population level. So it could be you're sitting 100 calories more than usual, or you're eating 100 calories more of sugar from that sugar sweetened beverage, right? And so it can easily explain these large shifts in BMI, right, over time. So that to me is motivational when you're working with patient population, that it's just that 200 calories. And so if you stand more at your desk rather than sitting, that might prevent the further weight gain, right? Okay, so I don't have to tell you guys about the importance of physical activity, but it's obviously a modifiable risk factor, so this is really good news. People can go from inactive to active, right? But we also know we have times in our life when we go from active to inactive, and we really have to struggle with the barriers, whether it be because you're a new parent or a new job or weather or whatnot. And so really thinking about how we can incorporate physical activity into our community, into our daily routine, so that we don't have those barriers. So I'm thinking now a lot about the interventions we do, and we were talking briefly about this, like your participants are gonna come in a couple of times a week for 3 months. and they're gonna have the instructors and the one-on-one attention, and then they're gonna go back to their real life. And are they gonna revert back to their behaviors? Probably. So what can we offer them to make it sustainable over time? And I love this, that there's no single medication that can influence as many organ systems in a positive manner as can physical activity at a very low cost and very few side effects. Okay, so Hannah Aram, a Trent Fellow from this past year with Heather's cohort, and she was actually one of my doctoral students too. She did this analysis that was published in JAMA, and it's actually like a meta-analysis of meta-analyses, and so it's very large sample size of prospective cohort studies with the primary endpoint being mortality, but she then looked at it for cancer versus cardiovascular disease, and you've seen this in other papers published. But really, her question was, is too much physical activity detrimental? And she found no, it was unequivocal that, you know, doing too much does not increase your risk of heart disease or cancer or mortality. But what I always like to tell people, more in a lay audience, is I ask them, what's the takeaway from this figure? What's screaming at you? Right. The part of the chair got it. It's the left side, right? It's you go going from nothing to just anything. You see this huge reduction in risk of mortality, right? So this is such a good message for those who think, oh my God, I can't go to the gym, or I can't run a marathon, or it doesn't matter. It's just going from nothing to something. Something's better than nothing. So having those messages to give your study participants, or to think of it as a research question, and also the importance of enrolling those who are inactive, because you're probably going to see the strongest effect. But who ends up wanting to participate in our studies? Those who are active. And it's a fine line, so like you're enrolling the insufficiently active because they're interested, but are you going to see as much of an effect with your intervention, right? So it's a balance in thinking about the rigor of your studies, and people always over-report their physical activity levels, and so it's really hard. But if you can study a group that's really inactive, you're probably going to see major benefits. And it's kind of shocking, right? Just nothing to something, and you see that. And an analysis I love that I think it was one of Irwin Lee's back from Harvard back in the day, and then there was an updated analysis. You know, the Weekend Warrior, that analysis, I love that because, you know, with being a parent and being busy, there's not enough time to get our exercise in. So I'm like, all right, if I have Saturday, I can get my 2.5 hours in on my Saturday, right? And get it all in, and there's a similar benefit to that one day a week and spreading it out over the week. Again, though, what's the end point? Is that for risk or mortality? Is it, but for quality of life, a daily bout of exercise is probably the best. So when you're formulating your theses or your research questions, think about, well, that might work for that endpoint, but does it work for this endpoint or this population? And what about all those other issues? And you can test them again in those different settings. Okay, so the mechanism. So many of you might know this, but there are 3 primary pathways when we think of exercise in cancer or obesity in cancer. And they're the estrogen pathway, the inflammation pathway, and the insulin pathway. And when we think about this from a breast cancer perspective, we know that in women who are premenopausal, they produce estrogen via their ovaries, but then when they go through menopause, they continue to produce estrogen, but through their body fat. And that's through the enzyme aromatase converting androgens to estrogens, okay? And so we know this is a really important mechanism because it is the standard of care of treatment for women who have estrogen receptor positive breast cancer, which is about 70% of breast cancer, that they are put on an aromatase inhibitor, which inhibits the conversion of androgen to estrogens. So what about exercise, or what about weight loss, or what about diet? What does that do to estrogen levels and whatnot? So this gives us sort of this rationale to study the impact of lifestyle behaviors. And so there's been evidence showing that as a mechanism. There's evidence showing inflammation and insulin showing that with just short-term 12-week long interventions, you can see a decrease in insulin and inflammatory markers. And that we know that higher levels of these markers, higher incidence of, or higher risk of certain cancers and higher risk of mortality. So by, what we don't know, and this is important to link studies that are intervention studies with like cohort kind of large prospective studies, is a 10% change in insulin, you know, that you get from your exercise intervention. What does that really mean from a cancer risk or mortality perspective? And how many weeks, months, or years do you have to maintain that reduction in insulin? So there's still opportunities to really better tease that apart with linking, I think, trials with large cohorts. Okay. So another slide getting at, so that previous slide was more the upstream, what we can measure in the blood. You know, you can do studies where you do a fasting blood draw before and after the intervention, see the change in these biomarkers, blood-based biomarkers. But what does it mean downstream? So what's really happening downstream? So we know that the insulin pathway is related to cell proliferation. So if you're changing insulin, are you slowing cell growth? Okay, and then there's cell survival and invasion and metastasis and angiogenesis, and you know, there's drugs. I mean, the pharmaceutical industry and many clinical trials are looking at drugs that either knock down these pathways or turn them on. And what is the role of lifestyle behaviors? So I think there's a lot of future research in working with pharma or working with those clinical trialists in doing trials of the medication plus or minus lifestyle behavioral interventions. And if you can look at how exercise might attenuate side effects of the drug while also having a direct effect on that endpoint, it's sort of a win-win. Maybe they need the drug, but by adding in the exercise, it's like an additive effect, right? And so maybe another avenue for funding, if it's challenging to get it from NIH, is from certain pharmaceuticals industries, because they want to look at attenuating side effects. And another area is how to improve adherence to taking the medication. So some won't take it because of the side effects, right? So they will either choose to not take it at all, or they'll take it and stop it. So what is the role of exercise or other lifestyle interventions in helping with the adherence to the medication? Okay, so this is some work I was fortunate to do with Ann McTiernan during my postdoc and years later, and Henry Thompson was involved with this group too out of the Hutch. And this is a nicely designed trial. So a 4-arm trial, and it was in postmenopausal women without cancer, and it was a sample size of over 400, so about 100 per group. The control group isn't shown here, but basically it's diet alone. This was a low dietary fat diet, high fruits and vegetables, versus exercise alone, which was primarily brisk walking on a treadmill or outside, the 2.5 hours per week, versus the combination. But what's the take-home message here? What do you see? Do you see a lot of negative signs? Yeah, so, and this was results at, she did a 3-month time point and a 12-month time point, and she found effects at 3 months. So in 3 months, you see, look at these changes in estradiol, leptin, you know, a 40% decrease in leptin, and CRP, a 41% decrease with just exercise, and then the combination is obviously an even stronger finding. But a lot of people won't necessarily, like a lot of comments I get in our study participants, they want to see a change in their body weight. And in the exercise group, there was minimal weight loss, but they had favorable changes in these biomarkers. So important to let your study participants know, even without weight loss, you're seeing favorable changes in these biomarkers within a short period of time. So I think these are powerful findings. And if a drug found this, there'd be a lot of money being made, right? From this, and there are drugs. There's metformin, right? And so do you remember do you all read in your classes the diabetes prevention program, the primary trial that was published in the New England Journal back in 2002? It was lifestyle versus metformin versus control. and you know the trial was stopped early. Do you know why the trial was stopped early? What was that?
Exercise was better.
Yeah, so the lifestyle intervention, which was exercise and a healthy eating, outperformed the drug, metformin, and definitely outperformed the control group. So much so that they had to stop the trial early so that the control group and the metformin group could have the option of starting to have this lifestyle intervention. That was in 2002, and there's been a paper showing this. Over the next 10 years, what did you see an increased rate of research being done in publications? What was it all focused on? Metformin. Even though the benefit was in lifestyle, and yet all the trials that had been done were metformin. Why? What? It's easier to take a pill. And metformin's pretty inexpensive. I think it's only like $10 a month or something. So you have to think about from your patient perspective, you know, we love exercise, right? But some people, it's not, you know, what we find as like a walk as moderate intensity, that might be vigorous intensity for them. They might not be getting any of those benefits, so they just want to take a pill. So we have to constantly remind ourselves, like, well, not everyone enjoys it, and yet we're trying to promote it. Okay. Okay, so another important finding is that this 5% weight loss you hear is clinically important, right? It's clinically meaningful. Well, it is. There's been meta-analyses showing that just a 5% weight loss is associated with a 15% lower all-cause mortality risk, and that this benefits on par with reductions in mortality risk associated with hypertension and cholesterol reduction, yeah? So just a 5% weight loss, so someone who's 250 pounds, that's just losing, you know, 13 pounds. And they think that's insignificant. They want to lose 100 pounds. But you have to make sure you're setting realistic goals with them. That, no, you know, let's just focus on the 5%, focus on adhering to the long-term exercise and factors related to that. Okay, so now I'm going to talk about a study that I've done it probably got started in 2009 or 10, called the LEAN study, Lifestyle, Exercise, and Nutrition Study. And we did, this is in women with breast cancer, and this was post-treatment after they finished radiation or chemotherapy. And I originally designed this study, and it was a 3-arm trial. It was a usual care group, or a telephone-based weight loss counseling, or an in-person weight loss counseling. And I designed this because I wanted to look at, is telephone as effective as in-person counseling? And if so, then we can scale it up and do it nationally and look at endpoints such as recurrence and mortality and other factors. And so we did that, and then after that first iteration, we found no difference in weight loss between telephone and in-person counseling. So we then continued this study, and then we gave the participants the option of choosing if they wanted over the phone, in person, or a combination. And so that's what we do now. And now we do a bunch of measures where we do, we recruit, in this case, this was post-treatment, and all they had to do was have a BMI greater than 25. They could be active, could be inactive, about majority were inactive, you know, similar to the US population, about 75% were insufficiently active. We, at baseline, collect a bunch of questionnaires, a fasting blood draw, a DEXA scan. We did breast tissue biopsies to look at, is our intervention changing anything in the tissue? And then we randomized them to weight loss or waitlist. So we do a waitlist control group. So at the end of the 6 months, that control group gets the intervention in its entirety. So it helps with recruitment because people don't want to be in a control group, helps in recruitment, but also it allows us to do a crossover design so that these controls, when we do a 12-month follow-up, we have more intervention data there as well. So this is a study we did. We also did a bunch of other measures. We did a salivary cortisol to look at stress, and collecting a stool sample to look at the gut microbiome and whatnot. And then this Raman machine, which is now called the Veggie Meter, and it measures skin carotenoid levels. It's another indirect way of measuring their fruit and vegetable intake. And participants love that when you do these little tests and you give them the information right then and there. So this trial enrolled about 151 women, very typical breast cancer population, average age of 59, mostly non-Hispanic white, in the Connecticut area, and highly educated though. And BMI of 33, body fat of 42%, about 3 years post-diagnosis, and primarily stage 1 and 2, and treatment that was related to their disease stage. This trial was exercise and nutrition, okay? And it was all done via 11 counseling sessions over 6 months. So it's different than when you think bringing them into the lab, training in, a couple times a week in these in-person training sessions. They did everything on their own and at home, but had the counseling to, either the telephone or in-person counseling to guide them, to educate them. So what it was is 11 sessions. We had weekly, and then every other week, and then monthly. So we front load teaching them, giving the skills and the knowledge, how to do it, how to exercise, what intensity, what to eat. And then they owned it and reported towards the end. They're telling us what they know, and we're listening and kind of guiding them. It was based on the dietary guidelines, 2.5 hours per week of exercise, and 10,000 steps per day. So we gave them Fitbits and made sure that they get to the 10,000 steps per day. Okay, as far as the diet, as Maura Harrigan, who's the registered dietitian who works with me, she's also what's called a CSO, a certified specialist in oncology nutrition. So if you're doing trials of exercise and nutrition in a cancer patient population, there's this certification that's important to consider, where they really understand oncology and treatment and all that goes along with that. But she will say it's all about portion control. If you literally just reduce whatever you're eating and just cut it down, that's going to help from a weight loss perspective. But then obviously it's about fat grams, sugar, fiber, and sodium and alcohol. So this is sort of we try to simplify the message for the study participants. So just thinking of the number 30 helps. And now that the food labels are changing, where it actually pulls out the added sugars, that helps them to count up their added sugars per day and compare fiber to sugar. So really trying to make it easy messaging for them and giving them the skills and the knowledge. And the 11 sessions, it's undoing this is not a diet. So many have this diet mentality where they're going to go on a 6-month diet, a crash diet, and it's a lifestyle intervention. It's changing their lifestyle so that it's sustainable over time. So there's a lot of that, skill building, reading labels, all that, and then sustaining these changes. And with the exercise, it's right from the beginning. There's a lot of people who think, oh, you got to ramp them up over a month or 6 weeks, and I'm like, just get them in there and get them going week 1, right? It's walking, and you got to get them up there. It don't take too long to get there, right? And more about really with the exercise, it's the time management, helping them figure out when they can get it in and what is the appropriate intensity and whatnot. We've now added in a home-based strength training program, so we have videos, and we have purchased dumbbells that are mailed to their house, and we have videos to teach them how to do various exercises in their home. It's not as good as in a gym, but it's sustainable. We also work with the YMCAs and the Live Strong program. So not all Ys, but a lot of Ys and a growing number are offering the Live Strong program. So we hook them up with a Y, even if they don't have the program, and we work out a membership so that they can go there during the study and train there as well. So we try to think about how we can do these interventions that is in their real world setting. Okay, most important with a cancer survivor population is that for some, or for a majority, cancer is the least of their concerns. They've got so many other issues. They're worried about the fact that they had to take time off from work, perhaps, and now they're worrying about bills and aspects related to that, their child care, adult care, so many other factors. It might be that their spouse also has a health condition. And so a lot of the study participants, when we're enrolling them, they're like, you just have to kind of meet them where they are. The other thing is the misinformation. There's so much misinformation out there. And so it's sort of how to honor where they are and what their beliefs are, even if you think they're a little wacky, how to kind of listen to it and start where they are, and then over time direct them to the correct information and knowledge. And then a lot of them have had surgery, and there's other comorbidities. So it's really important when you're intervening in a cancer survivor population to make sure you've got some sort of counseling aspect where you're taking in other related factors. Okay, so what did we find with the 6 months? So this was a 6-month home-based intervention with 11 calls or in-person sessions over the 6 months. So change in body weight was about a 6%, between the blue is the telephone, the purple is the in-person, so really no difference, both about 6% weight loss. The control group, which is the usual care group, had about a 2%. So what do people always ask for that? What do you think? What happened with the control group? How do they always ask about the control group? I'm like, but look at the intervention group. Well, because think about who participates in research studies. Those who were really motivated, right? And they got randomized to control, and they're like, well, I want to lose weight, so I'm going to figure out a way to do it on my own, because they're highly motivated, right? And so they lost some weight, but it wasn't at the effect size that was with the intervention. And then we measured 12 months after that, sort of your maintenance group that you watch, and it's reverted back to either they've gained that weight back or there's sustained loss in the intervention group. So it's important to always measure what happens when the intervention ends, right? Okay, from the biomarker perspective, we saw about a 30% decrease in C-reactive protein and about a 10% decrease in insulin and 15% in leptin. So we were happy with this. It was, just kind of a low-dose intervention. The participants was individualized, so it wasn't group-based, working with them, meeting them where they're at, what they're able to do, and we felt like we saw clinically meaningful changes in these. So now with this group, we also found, attendance to the sessions, a dose response and weight loss, as you might expect, so more attendance, more weight loss, closer now to 8%. And then the change in physical activity, so and this was measured by questionnaire, but also when we looked at pedometer, change in pedometer steps, that those, of course, who did more exercise had greater weight loss. And in an analysis that Mary Playden is doing, what were the predictors of weight loss, the number one predictor was change in physical activity. So that really, you always hear that physical activity is important for weight maintenance, but in this case, it was really one of the strongest predictors for weight loss too. And then looking at lean body mass, when you lose weight, you lose some lean body mass. But we saw, this is not different between the three groups, but an attenuated loss among the intervention groups. So there's so much research being done now in looking at sarcopenia and lean muscle mass and toxicity and with chemotherapy, and so there's a lot looking at that measured via CT scans and DEXA scans. So a lot being done to both exercise versus weight loss via diet and then the changes in that. So really, you should look at that with the DEXA scans. Okay, so some additional analyses we're doing, we have lots of students like you guys, and so they can do make sure whenever you do a study, you collect extra blood so you can store it, you use processing, so it's serum, plasma, Buffy-Co, and there's lots there. We take about 50 cc's of blood, so about more than 4 tubes, and then it ends up being about 40 different cryo vials, and so we can, for thesis projects and whatnot, do different analyses. So we're doing our breast tissue analyses, and we're looking at all these different factors. Why? Some might be like, why do you have to do all these other analyses? And my perspective is, unfortunately, because people still don't believe that, just 6 months of brisk walking and only losing 5% body weight actually can impact these cancer outcomes. So the more evidence on all these different endpoints, that it just piles up to really be more convincing. And then hopefully it's convincing enough that it just becomes part of standard of care, right? Okay, so now where we are is that when I finished the LEAN trial, so much of information we got from the study participants, remember that was about 2 years, 3 years post-diagnosis. And just in the consenting process, we had to tell them, you know, we're doing an exercise and nutrition intervention on these outcomes. And they'd be like, why? Well, there's evidence showing a benefit. And they're like, well, why didn't I find this out when I was diagnosed? Like, no one told me that exercising was important. And why are you telling me now, 2, 3 years later? They were mad. They were really mad that they didn't hear this before surgery or at the time of, you know, around that time. And so we're like, you're right. Why aren't we doing this intervening at surgery? So we wrote the grant, and we have the study where now we're just 1 year into recruitment, so we've enrolled 45 women. These are women who are receiving chemotherapy for breast cancer. And so we recruit them, Smilo Cancer Hospital is our cancer hospital. We recruit them usually right after surgery. It's tight, it's, you know, doing these post-treatment studies are so much easier because there's no like rush to enroll them. But here we're enrolling them right after surgery, and they start chemo within about a month. And so you've got to screen them and get all this data collected, all these baseline measures, and then randomize them. And so they're stage 1 to 3, but it's really 2 and 3 because a lot of stage 1 don't get chemotherapy. We recruit them, and they're any BMI level, but they're physically inactive or insufficiently active, and eating a poor diet, which is really hard to measure. As you know, the FFQ and the 24-hour recall, it's hard. So we've kind of, our screening questionnaires, how much fruits and vegetables they're eating. And what we do is we collect all this data at baseline. They haven't started chemotherapy yet. And then we randomize them to a year-long intervention or referral to our survivorship clinic, which is where they meet with a dietitian, a physical therapist, exercise trainer, and a social worker, and they meet with an APRN or an oncologist to get kind of an end of treatment summary report. So that's sort of our standard of care. It's a little bit enhanced. And then our intervention is now, we went from the 11 sessions to 16 because it's a year long, where the other trial was 6 months. So it takes them all the way through their chemo and post-chemo. And so we have 4 time points. We have before chemo, at the end of chemo, 1 year, and then 2 years. The intervention's only a year, and then that other year is to like maintenance to follow up. And what we're looking at is our primary endpoint is chemotherapy completion rate. So what do you think is, if we're talking just breast cancer, what do you think is the chemotherapy completion rate? How many women who receive chemotherapy for breast cancer complete their chemo? Take a guess.
70.
All of them?
75.
75?
62.
So there's been, most of these analyses are retrospective, but MD Anderson had 2 publications with a large sample size, and we published something with a smaller sample size, but they were similar chemotherapy completion rates. So we define chemo completion as either dose reductions, right? So there's a reduction in their dose, and why would there be a reduction? Because of side effects, right? Fatigue or neuropathy are the 2 primary reasons why there's a dose reduction or a dose delay. They wait a week and they reschedule your chemo for a week out because of the side effects, right? And so we look at those together, 50%. And these are at academic medical centers where care, you know, where only 15% of patients diagnosed with cancer across the country get their care at an academic medical center. And that's, you know, so it's, and they're only meeting 50%. So there's so much room for improvement. So we hypothesized that exercise and nutrition would improve the side effects and in turn improve chemo completion rate. We don't know because we're doing the study, but we hope. And then we're also gonna look among the women who are estrogen receptor positive and who are taking endocrine therapies, either aromatase inhibitor or tamoxifen, adherence to those medications, because there's side effects that are different. So with the AIs, it's joint pain. Some don't even want to take the medication because of fear of joint pain. Some take it and stop it. So does our intervention help in those uptake of the medication and then the adherence to the medication? And then biomarkers and body comp. So it'll be interesting. It's so challenging. So we've enrolled 45, we have to enroll 250. In our progress report that we just submitted for in February, we just got the NCI comments back. I don't know about you, Henry, or the others who've had NIH grants, but it used to be you submitted a progress report and we never got comments, it's fine. They are now really critiquing your progress more than I've ever seen before. And if you're not, I'm not sorry to stress you out, but you have to have alternative plans for recruitment or how you're gonna change your eligibility, or if you're not meeting your effect size, or if there's dropout. So it's getting, I mean, it's good that they're doing that, but it's getting a little challenging. So we are a little delayed in recruitment. Why are we delayed in recruitment? Well, it's a good thing. Fewer women are having chemotherapy for breast cancer because there's something now called the Oncotype DX. It's a test you do from your blood draw. It's a panel, looks at 21 genes in your blood, and if you have a low Oncotype DX, then chemotherapy, you don't need it. It's not gonna improve your prognosis at all. So this is great news. It was a huge finding at ASCO last year, American Society of Clinical Oncology, where they had this finding. And so this is really great news. But for us, we're like, oh gosh, how are we gonna meet our recruitment goal, right? But, so we've just had to figure out, we're gonna partner with some other, become more multi-site, because the end point to get this data is all through electronic medical records. You know, their chemo regimen is in their electronic medical record. And because I tested these interventions, telephone or in person, we can do it across the country. So we're now gonna open it across the country and maybe surpass our recruitment goal, who knows? But, so we're really excited about this study. It's brought on so many different challenges, but opportunities too, because now what I'm thinking about is how can I have some postdocs or pre-docs or students look at, can exercise improve the effectiveness of chemotherapy? So that's a different kind of direct benefit. Can it somehow make the chemo more effective in doing its job? And there's all these other questions to ask sort of in this during treatment period. And then you could think about, you know, colorectal cancer during treatment and all these other cancers. So there is evidence, and this is an exercise-only trial done in Europe by Van Moort that was published a couple years ago. So you probably can't see this well, but this was exercise only during chemo for breast cancer. They had a supervised in-person exercise training, a home-based, and then a control group. And so patients requiring dose adjustments. The supervised was the best. Only 12% needed a dose adjustment. The home-based 34% needed a dose adjustment, and the usual care 34%. So really no difference. But then when you look at the average dose reduction, it was similar, about 10% for both exercise groups compared to 25%. So you see here 34% and 25%, that's over 50% poor adherence. And so they showed that exercise, this was, in ours is exercise and nutrition, which we hope will add a little bit more. So there's evidence of this, and this is the only study that I know of that's been published. Carrie Cornea did a post hoc analysis of this and showed a suggestion of exercise too being beneficial. So there's a lot of movement, I think, in this area. Okay, so just, I mentioned our goal is 250, we're at about 45. So the great news is the women have adhered. They've been able to do this during chemo. You know, a lot of times it's like, oh my God, they're undergoing chemo. Now we're telling them to walk 10,000 steps per day, and they're not regularly active. We've been able to do it. When the trainers and the dietitians give the stories of a counseling session, and it's just like, we'll be like can't remember the end of these meetings because these women have just had it's had such an impact on their lives and how it's had a ripple effect to their spouse and their children and stuff too. However, what we're finding a challenge is that when we're trying to consent and recruit these, half don't want to do it at all. They're overwhelmed with their diagnosis. They cannot even think about any of this. And so how do we, and they might be the ones who need it the most. So there's some observational studies that can be done, so some thesis projects in that population setting. What type of intervention would be beneficial at this time? You know, if this is overwhelming, you know, what is the best time for them? When we know if you wait they could have benefited having it earlier than later. And so we're still having to figure out how to message it better for this time in their life. We've had to change a little bit of our eligibility criteria, and now we're opening it at other sites across the U.S. Okay, some of you might be aware of a trial done by Jen Ligabell it's out of the Alliance Cooperative Group, and that's a whole nother discussion we can have about how to do cancer research and exercise and whatnot through these large NCT and the National Clinical Trials Network, which is around the country. Happy to discuss that another time. But this is a trial done through that, where the endpoint actually is recurrence and mortality. So it's an exercise and nutrition weight loss in breast cancer on recurrence and mortality. So many people be like, don't we already know that? No, we only have observational findings, but we haven't had an actual randomized trial of these behaviors on recurrence and mortality. So that's being done, and those findings will come out in about 3 to 5 years, and we'll see how it changes the field. If they're positive findings, then hopefully this will become more standard of care. And you know how there's cardiac rehab programs everywhere, there'll be cancer rehab programs everywhere. Reimbursed too, right? Okay, but who cares? Who cares if there's no effect on mortality or recurrence or chemocompletion rate? We all know it improves quality of life, improves bone health, it improves diabetes, cardiovascular disease. We know all of this already, right? So that's why we were talking about this earlier. Some funding agencies or lay people will be like, don't we already know this works, so why are you still researching this, right? So it's important to know that when you're writing your grants. Well, if people think we already know this, how do we let them know what we don't know and how to formulate that question? So in closing, I'm just going to present a couple slides on where I think we need to go in the future, because as the evidence accumulates as to the benefit, are we done? Are our careers done in regards to cancer, but even cardiovascular disease that are years ahead? What do we still do, right? And so, well, we need to really implement it as a part of standard of care. And so in regards to cancer, ASCO came out with some priorities, so increasing patients' knowledge of the benefits, developing tools and resources, more research, and then improving access to treatment, right? And then you know about the Live Strong at the Y program and getting survivors to enroll in those programs. So what I've been kind of looking at is Medicare reimbursement. And so, what is that, 8 years ago, Centers for Medicare and Medicaid, you may have read this, it was like headline news, they are going to now cover reimbursement for weight management counseling. And it's a lot, it's about 18 sessions over a year or two, and so this is great, reimbursed. But in 2008, 33% of reported decline. So primary care physician-based weight management counseling was only 33% in 2008, and it's dropped now to 21%. So here it's now, if you build it, will they come? So now we've created a reimbursable model, but no one's using it. So that, you have to think about that from your research perspective. We're doing all this to ultimately change the standard of care so that, clinicians will counsel and offer it and patients will do it, but yet they're not. So starting to think about that from a research perspective of all that we're doing, what's it gonna lead to? And so, why? Why are physicians, what are the challenges? Well, they have short clinic visits, lack of knowledge and training, so are they the ones that should be doing the counseling? and discomfort with discussing weight issues. So these are more research questions here. How do we implement this exercise and weight counseling when the physicians have all these barriers? And so Tom Wadden, who was a part of the DPP, this is I think it's the previous publication, that one's a good paper to read. But he analyzed, he did a review, a systematic review of all the exercise and weight counseling interventions for any different disease outcome. And he found at the end of the day that it didn't matter so much who was doing the intervening, if it was an MD, RD, exercise scientist. It was more about treatment fidelity, following the protocol and delivering the appropriate protocol, following that protocol. And so what he worked with the DPP, that now the YMCA's train lay people on how to deliver the DPP intervention, and they become DPP lifestyle coaches, and they're the ones now delivering the intervention. So they're not MDs, they're not even RDs or exercise trainers. They've kind of become skilled in that a bit, but they know how to deliver the intervention and follow the intervention. And that's now what's being reimbursed. So there's a lot to think about that in the interventions you're doing, is how to get these to be disseminated and implemented. And they're following the smoking cessation model of using the 5 A's and how to do this kind of counseling sessions. And this has been what's recommended from the National Cancer Policy Forum. So in closing, Julia Rowland, who's retired from the Office of Cancer Survivorship at NCI, she just published this paper about a month ago. These are her 7 areas for future research. So for you interested in this area, thinking about research among diverse populations and various cancer sites, there's been so much done in breast cancer, of course looking at different racial and ethnic and geographic diversity, older individuals, long-term survivors, those with multiple malignancies, addressing neglected outcomes or side effects of cancer, and then the impact on the caregiver and these dyad studies, research going on there. So this seems to be where NCI is going to fund research. So thinking about if you are a PhD student, you're wanting to start a career, thinking about making your area of expertise in this area. And then I'll close with the TREC program that was mentioned. And so really the rationale for starting, so as you might know, TREC was Transgender Research in Energetics and Cancer was this 10-year NCI funded, where 8 different sites were funded, and they each had about 3 or 4 R01 type projects. So there was about 30 projects done, basic clinical population science research, prevention and survivorship. And there was a training component, but then it ended. And so we thought about, there was a bunch of us who were on grant review panels, reviewing grants, and we were a little worried that the rigor of the studies being proposed weren't really moving the field forward, and that there was an opportunity here to make sure the early career investigators get that additional layer of training to boost their grants to be that much more clinically meaningful or significant or innovative. And so we have this 5-year funding where we're going to train over 100 early career investigators, and hopefully it'll lead to more impactful research being done in this space. So, and then just my closing slide, I like to think about how we can implement nutrition, exercise, weight management as a part of, survivorship care, surgery, chemotherapy, radiation, so that from a patient perspective, we're not just treating the disease or the tumor, but we're treating the whole patient. And they welcome that, they want that. So, thank you.